So in general, here are some tips for what we expect for insulin management during diabetes. If we are lucky enough to get our patients preconception, which as you all know is quite difficult, generally I talk to them extensively about what I expect for them. As you know, most of our patients, particularly those with type 1 diabetes, are not checking their blood glucose values as reliably as they do during pregnancy, and so therefore we have that discussion. I want them to have smooth glucose control, avoiding hyper and hypoglycemia, and have a reliable regimen. I also want them to have an A1C at the beginning of pregnancy or preconception of less than 7% to minimize adverse fetal complications such as the risk of congenital anomalies. As you know, there's a linear relationship between congenital birth defects and an increase in hemoglobin A1C. In the first trimester, I'm cognizant of the fact that I'm going to have to cut back their insulin by as much as 15% up to about 11 weeks, and that it later flattens out to about 14 weeks, where it starts to increase in a linear fashion. And then in the second and third trimester, that insulin needs to be increased weekly or more often. We do review their glucose targets, which are to maintain the fasting less than 90 and the 1 hour postprandial less than 30. And we generally increase their insulin doses when we see that 3 or more of 7 values are elevated above the target. So let's talk specifically about insulin management in type 2 diabetes and gestational diabetes. Generally in my clinic, I tend to use the old school way of calculating total insulin dose. What I do is calculate, again, the insulin total daily dose by weighing the patient, converting that to kilograms, and then multiplying by the units based on the gestational age at which they are in pregnancy. I then divide that total dose into a 2/3 fasting dose and a 1/3 non-fasting dose. Furthermore, I subdivide that 2/3 fasting dose into 2/3 NPH, which is the insulin of choice at UCSD, and we'll review why later on in the presentation. And then 1/3 of that is divided into a Humalog to be given to control the postprandial breakfast values. The 1/3 non-fasting dose, is then divided into half and given with dinner to control their postprandial dinner values, and half of it is given after 10 p.m. to control their fasting blood glucose values. The California Diabetes and Pregnancy Program actually has a different calculation for calculating the basal insulin, which I will review here. You utilize the same sort of criteria to calculate the total dose of insulin. You divide that by half, and half of that is given in the bolus and basal insulin dosages. The basal is then divided into half. Half is given at bedtime, and half is given in divided doses to control the pre-meal insulin boluses. The bolus insulin, the other half of the insulin that you calculated, is divided by the number 7 and then multiplied by 3 for breakfast bolus doses and times 2 for lunch and dinner. Again, this is slightly different than what we do at UCSD. It's important to realize what a normal glucose pattern looks like in a typical day in our patients with diabetes. And so this is a nice figure depicting that. On the y-axis, you have the blood glucose values in milligrams per deciliter. And in the x-axis, you have the time of day. In the white, you have a figure representing the insulin resistance changes that we expect during the day. And in the purple and blue, you have the the corresponding glucose values. The red is our patients with diabetes, and the blue is a normal control. As you can see, in the early morning hours, we have the lowest glucose values, which corresponds to what we call the dawn phenomenon, which then leads to an increase in the insulin resistance early in the morning, or later in the morning, I should say, at around 6 to 8 a.m., which leads to a fasting hyperglycemia that we all encounter. Then throughout the day, you have these peaks, which correspond to our meal times, and then these valleys, which correspond to our preprandial blood glucose values. And as you can see, insulin resistance is typically highest in the morning and then slowly decreases throughout the day, possibly due to an increase in activity level in the patient. So we have to keep this in mind as we dose the insulin for a patient with diabetes. So how do we choose the corresponding insulin to utilize? Well, generally, why do we choose regular versus Lispro? As we discussed earlier, the onset of action for regular insulin is actually longer than that for Lispro Novolog, and so therefore it must be taken about 30 to 60 minutes before a meal. And it can also have a hangover effect. In other words, it lasts longer and can affect your pre-meal glucose values. Lispro, on the other hand, is very quick acting and can be taken at the time that you start eating a meal. Obviously, this actually is easier to use as patients have a lot more autonomy. They're able to give themselves their insulin right as they begin eating. And if their meal is delayed, they can avoid having hypoglycemia. This is particularly important for patients who are on insulin pumps and also who have type 1 diabetes, as it has little effect after 2 hours and therefore doesn't potentiate between meal hypoglycemia. We utilize NPH in our clinic to control pre-meals and to control fasting plasma glucose values. As you recall, NPH peaks at about 4 to 7 hours and is usually gone by 13 hours. So we utilize that to maintain our pre-meal glucose values anywhere from 80 to 100 milligrams per deciliter and to control the fasting plasma glucose. Generally speaking, I instruct the patients to give the insulin anywhere between 10 to 12 p.m. To avoid potentiating the dawn effect and worsening the hypoglycemia that happens at around 2 to 4 a.m. And then just a note about Lantus. Remember that Lantus does not peak, so that can really potentiate the intermeal hypoglycemia, particularly the seen in type 1 diabetes. However, I do tend to use Lantus in our patients with type 2 diabetes, as they tend to have lower rates of hypoglycemia between meals. So if we go back to our picture that we discussed earlier, the way I dose the insulin is I give insulin at NPH at around 10 to 12 p.m. Again, to treat the fasting hyperglycemia that we see at around 6 to 8 a.m. and avoid impacting the dawn segment. I also use Humalog at breakfast and Humalog at dinner to treat the postprandial values. And then I instruct the patient to inject AM NPH along with her breakfast Humalog to treat their postprandial values at lunchtime. However, there are a subset of patients that this AM NPH is not enough, and I make a determination to instruct them to give themselves Humalog prior to lunch. And I make that determination by having them check their pre-meal glucose values. If those are excellent and they're still having postprandial elevations, then I instruct them to add a Humalog dose at that time. What about our patients with type 1 diabetes? Well, with type 1 diabetes, remember, most of our patients come into pregnancy not checking their values as often as we do during pregnancy, so it's important to educate the patient. Generally, I have them check a lot more times than they do normally, which include fasting prior to meals, 1 hour after meals, bedtime, and then 3 to 4 a.m. to evaluate how their dawn segment is going and make sure they're not developing hypoglycemia at that time. In terms of insulin, for type 1 diabetes, we can use both multiple daily divided doses or insulin pumps. Generally speaking, when we use multiple daily doses, I use NPH to control the fasting and pre-meal glucose values, and then again Humalog or Novolog to control meals. The advantages of multiple daily doses is that it really allows for patient control and autonomy. Our patients really do report that they have a lot more control by being able to give themselves these doses of insulin themselves. Some patients really have a problem with the insulin pump because they don't feel that they have as much control. The disadvantages, of course, are that at times, particularly in the third trimester, we're giving large boluses of insulin, and absorption is a problem. Generally speaking, to counteract these issues with absorption, if a patient is injecting more than 40 to 50 units of insulin at a time, I usually have her divide the doses in half and give it to herself at 2 different sites. It's also a little difficult to get smooth glucose control with multiple daily doses and requires multiple injections, which of course are associated with patient discomfort, particularly if they're dividing their insulin doses, as I stated above. So this is a nice figure depicting a glucose profile in patients with type 1 diabetes, which is in the black, and then normal glucose profiles in the normal pregnant patient in the yellow. As you can see, in the y-axis is the glucose values, and on the x-axis is the time of day. Again, you can see the 2 to 3 a.m. hypoglycemia that occurs in all patients, but particularly so in type 1 diabetes patients, and then the hyperglycemia in the morning. And then you see this hyperglycemia that usually occurs during dinner time. In most American diets, that tends to be our largest meal of the day. Generally speaking, again, I instruct patients to administer insulin at around 10 to 12 a.m. to control their fasting glucose values. I avoid them injecting NPH at dinner time, as this, in my experience, has potentiated hypoglycemia during the dawn phenomenon, as the NPH tends to peak at that point in time. And so with Lantus, I would just be careful. Again, it doesn't peak, and it tends to potentiate hypoglycemia that we normally see in these patients, so be careful with the use of Lantus. Now, what about the insulin pump? Well, there's some clear advantages to using the insulin pump. For example, carrying insulin and supplies, including syringes, is unnecessary with the insulin pump. Boluses can be given at any time during the day, so if the patient has a snack that she normally would not have and is pretty carbohydrate rich, she's able to give an extra bolus. The pump can also be placed on suspend if the patient is experiencing some hypoglycemia, is planning on exercising, or has a delayed meal. And bolus and rates can be modified into several programs if the patient, for example, has a night shift. This is particularly important for patients who are nurses and different types of shifts. We can set their pumps into several programs.